The Senate Committee on Health, Education, Labor, and Pensions will please come to order. This morning we're holding a hearing on America's health IT transformation, translating the promise of electronic health records into better care. Senator Murray and I will each have an opening statement, then we'll introduce our panel of witnesses. After our witnesses, senators will have 5 minutes of questions. Now we have 2 votes at 11, and that should give us plenty of time to get through our opening statements and hear from the witnesses and some questions. We'll see where we are about 11:20 in the first vote, and if we're through, why we'll conclude the hearing. If there's senators who still want to stay and ask further questions, why we'll work it out where some of us go vote and some of us come back. So we'll work it out so senators all have a chance to participate. Health IT means many different things, everything from wearable gadgets that monitor your heart rate to sophisticated applications to help physicians track treatments. But today, we're focused on electronic health records used by hospitals and doctors in their practices. Our committee hasn't had a hearing on health IT since January of 2009, a month before the $35 billion HITECH Act became a part of the stimulus package. The HITECH Act was warmly greeted. It was meant to unleash a new IT era where our health information would move seamlessly among doctors and hospitals to help achieve better, more coordinated care. After the bill's passage, doctors and hospitals rushed to join the so-called meaningful use program. There were $35 billion in incentives to encourage that. Adoption rates for electronic health records grew dramatically. According to the most recent data, 48% of physicians, 59% of hospitals have at least a basic electronic health records system, compared to 26% and 47% in 2009. The hope was that the program would improve care, coordination, and reduce costs. The evidence suggests these goals haven't been reached. Half of physicians have not met the requirements of the program and are now facing penalties. A medical economics survey last year found nearly 70% of physicians say their electronic health record systems have not been worth it. One physician wrote, "We used to see 32 patients a day with 1 tech, and now we struggle to see 24 patients a day with 4 techs, and we provide worse care." Doctors and hospitals have had so much difficulty meeting the meaningful use requirements that CMS has had to delay or change requirements 3 times. So we're here today to find out, how did this happen and what should we do about it? Transitioning to electronic health records requires a real transformation in how physicians practice. The administration seems to have complicated the process by rushing ahead with penalties for those who don't adopt electronic health record systems. To be specific, doctors and hospitals that don't adopt these record systems lose 1% of their Medicare payments in 2015. That penalty grows to 5%. To receive incentive payments, physicians and hospitals had to buy systems certified to federal government specifications. Providers assumed the certified systems would be high quality and meet program requirements. Instead, many providers discovered that certified systems have to undergo costly upgrades on short timelines to meet new requirements. Providers have to pay for these upgrades or pay even more to switch vendors. Hospitals have spent hundreds of millions of dollars to implement and continuously upgrade their systems. For example, Wellmont Health System, which operates hospitals in Tennessee, went through a complete IT conversion from one system to a new one that guaranteed they'd be able to meet the requirements of the Meaningful Use program. Wellmont spent $125 million and expects to receive $38 million in Meaningful Use dollars. Wellmont's also seeing an approximately $10 million increase in annual IT costs, but hasn't been able to calculate potential savings. Many providers are struggling with interoperability. Here's another example. Children's National Medical Center in Washington spent $400 million on its health IT over the last 4 years to make a web of 138 different electronic healthcare systems talk to each other, work together. That medical center received $28 million in incentive payments. The eye centers of Tennessee, with 5 locations, spent $731,000 trying to comply with all the programs, but because they weren't able to meet one measure, they expect a $100,000 penalty. This should have been a really good idea. For some, it has been. Vanderbilt, for example, had an award-winning program that includes patients' genetic information in their medical records. That system prevented a patient in her 80s from receiving a blood thinner that would have metabolized poorly because of her genetic variation. Instead of the government trying to make everybody do this by taking away Medicare payments, a better route might have been to find ways to enable and encourage their adoption. But instead, the administration seems to have rushed the process with its penalties, and at the same time made the federal government the arbiter of IT quality. Reminds me of a lesson I learned a long time ago in 1980. When I was governor, I flew out to Palo Alto to meet Steve Jobs. I had the idea of having every 8th grader in Tennessee computer literate. So we bought Macs, which then were about 4 feet tall. And we did that for every middle school in the state. And we had a mandate. Every child will become computer literate. I forgot one thing: teacher training. It sounded like a good idea to make everyone use computers, but I should have spent more time finding ways to enable them to use computers. Enabling instead of mandates. That appears to be a good lesson for Washington policymakers who have rushed ahead with penalties in this program that now has created so many unhappy physicians and hospitals. I'm interested in learning today how we can become enablers rather than mandators. Senator Murray.